138. We are called to order. At this time, I'll call for any citizens wishing to address the committee. I'm told there are none. Is that right? That's good. Matters to consider before the committee. Approval of minutes. The March minutes have been appended, updated, and are in front of you as amended. And I'll either look for discussion or a motion to accept as written.
Motion to accept.
Moved by Rex and seconded by Dorothy. Any other discussion? All in favor say aye.
Aye.
Opposed, same sign. Okay, so the minutes are approved as presented. So we have approval of Tarrant County Hospital District policies or plans. Item number 1 is an archival of procedure 1229, which requires no action. It's leaving against medical advice and patient elopement, and my understanding is that is to be deleted, and come ahead, Wanda, and then to be moved onward to item number 2, which is approval of policy RI 1500. Is that correct, according to you, Wanda?
Yes, sir.
Okay, ma'am, what would you like to say?
The reason we're doing this is the first policy was kind of embedded into another policy. It was part of the provision of care policy, and it was hard for staff to find and navigate the system. So we're just pulling it out and making it a patient's rights policy where it fits more appropriately.
Okay.
To make it more accessible to staff.
Okay. And do we do these item at a time? We can't block vote?
I will go ahead and do it.
Okay. Any other discussion or comments? I look for a motion to approve policy RI 1500.
Move approval.
Dorothy moves, second. Rex Hire. Discussion? All in favor, say aye.
Aye.
Opposed, same sign. There are none, so item 2 is approved. Item 3, approval of policy LD 1700, oversight and quality monitoring of contracted services. Mona, here she comes. What would you like to say?
Not much, sir.
Okay.
What would you like to say on this?
Would you like to chair this committee? Yeah. What would you like to say on?
Good afternoon, ladies and gentlemen of the Board of Quality Subcommittee. My name's Mona. I'm the Executive Director of Quality, and I would like to bring forward for your approval policy LD 1700, Oversight and Quality Monitoring of Contracted Services. No significant changes have been made to the policy. We wanted to make sure that our terminology was consistent with the Joint Commission and the Centers for Medicare and Medicaid, CMS, verbiage, and we also wanted to make sure that it was consistent with our quality assessment and performance improvement program.
Okay.
Move approval.
Moved by Dorothy, second. DT Wynn, seconds. Oh, yes, ma'am. Discussion?
Yeah, no. Second.
You're just seconding. Okay.
Yes.
Glad to have you. Okay. Any other discussion? Okay, we'll vote on the motion. All those in favor say aye.
Aye.
All opposed, same sign. There's none. That passes.
Thank you.
Thank you, Mona. Nicely done. I couldn't have done it better myself. Next, approval of proposed modifications and additions to the Tarrant County Hospital District Medical Staff Bylaws. Dr. Schrader?
Thank you, sir. So I would be happy to approach this however the committee would prefer. The medical staff bylaws, sections 3, 4, and medical staff rules and rights were submitted to MEC and approved, and then submitted for your reading and enjoyment. I would be happy to answer any questions if that's maybe the preferred way of approaching this, or to walk through different parts, kind of discretion of here.
Okay.
The one change I did note, part 4 of the bylaws, we have inadvertently left off family medicine as a department, so I will need, as part of this motion, to make sure that we include Dan Casey in the department.
Well, I don't know
We will
why.
never forget Dan Casey. So let the notes reflect, Dan Casey will never be forgotten.
Can I ask a couple of questions that I have?
Yes, ma'am. Please do.
Have you deleted getting references for when you are applying for credit? Is that one of the?
So on
if you go
section 3.
3.1, I think is 6. It's scrapped out. If I'm looking at that correct.
Yes, so I can speak to this. So Joint Commission just requires that we do our due diligence in appropriate background and assessing that they are able to perform the duties they request. It does not delineate whether you have 1, 2, or 3 references.
Okay.
Where this gets us a little bit of trouble later on is if we dictate the amount of references we have, then we have to hold that to our temporary privilege requirement as well. And so by not having a set number there, then we can then delineate in our temporary privileges how many references could be allowed to provide temporary emergency privilege.
So like, the answer is you would still get references, just won't have a number?
Yes.
Okay.
Yes. Well, we'll have a number that we determine internally, but we do not have to put
Put
it
it in the back.
in those grants. Yes, sir.
The other question I have is on 3.2. You know, I haven't had a lot of time, I can go through all this.
That's all right.
3.21 is, when I read that, if there's any inadequate information after they've been approved, is it a voluntary withdrawal of those privileges? And what if the doctor said, well, that's not enough for me to voluntarily withdraw? Is help me through that one.
So I would defer to legal counsel, but my quick version would be is it allows the ability for it to be considered a voluntary resignation. So
I think it puts
in-
the control on their side as opposed to the applicant side.
It's on the hospital,
Yeah.
the medical staff
On the
side.
medical staff side.
It would just be, if it's incorrect, it would be a voluntary, you'd say it's voluntary, but it's mandatory for that person.
And I think the other thing too, they're trying to make sure that there's not any way to implicate the fair hearing process.
Right,
Because-
right. I just kind of saw that.
Go back to Mr. Bo's question on voluntary and mandatory, because I want to make sure, Alan, that you're addressing that for Mr. Bose. Dorothy, ask that question again on the voluntary and the mandatory.
It read that if there's any incorrect information after they've been approved, then that would be a voluntary withdrawal of.
So we allow the verbiage purposefully that it may be a voluntary piece of information. So for example, if somebody had left off their felony convictions,
Yeah.
then we may choose to accept their voluntary resignation. If somebody missed, inadvertently put a date wrong, then we could allow them to correct it. So it really puts the ability to determine the voluntary resignation privileges on the medical staff.
Okay, all right, okay. Then I had one other question,
Yes, ma'am.
and it's over on your section of medical staff committees. I noticed that you have,
Dorothy, what page you on?
In part 4,
yeah,
I've dreamt about these. I have them memorized.
it's on 143, page 145. That's where it starts. And but my question is, you are deleting trauma quality OR committee, and they served a purpose, so now who will do that? Where
So-
will that responsibility
So
go?
those committees still reside, but under the hospital quality structure instead of under medical staff subcommittees of MEC. So those committees are not going away. It's a reorganization.
They report to Dr. Webb's committee.
Patient safety and quality governance.
So all of those committees that you have deleted are just moving over out of the bylaws?
Yes, ma'am, which is functionally how we've been operating. So we are making our bylaws to be consistent with our operations as we have our quality arm and then medical staff arm.
Okay, all right, that was my, I think that's the last one I have. Okay, all right.
Okay. Other questions or clarifications or comments? I would accept a motion to do whatever, approve. Dr. Weber? I'm sorry, comment?
Sorry, with an amendment to
I'm sorry.
re-input in family medicine,
With
please.
the re-input of the Family Medicine Department, casting no aspersions or leaving no one out. All inclusive. So, moved by Dr. Weber, second by? Reverend Pastor Emerson. Okay, other discussion? We'll call the question on the motion. All in favor of the motion, say aye.
Aye.
Opposed, same sign. There being none, that passes. Item number 4 is done. Okay, moving along to consider performance improvement reports. Ms. Mona, Call your name again. Did you change your hair since you spoke here last? Sorry, just messing with you a little bit.
It's actually shorter.
Okay. I'm part of the hair cutters union. I just wanted to know. Thank you, Mona. I will not do that again.
You're okay, sir. Good afternoon again, honorable members of the Board of Managers, Quality. So I'm going to present to you a brief overview of the Patient Safety Culture Survey that we conducted at JPS for the month of January and February 2017. What is the Patient Safety Culture Survey? The survey is actually has been developed by the Agency for Healthcare Research and Quality, AHRQ, as a tool for hospitals in the U.S. for these hospitals to be able to measure the culture of safety in their respective organizations. The Joint Commission and the Leapfrog Hospital Safety Survey recommends conducting the patient safety culture every 18 months to ensure that hospitals are able to identify, measure, and create action plans on improving conditions that may create an adverse patient safety event. Why is the Patient Safety Culture Survey important? And as I mentioned earlier, it does allow us to create action plans on how we can improve conditions to make our patients safer here at JPS. Secondly, it increases staff awareness on our current safety culture. And then third, it allows us to learn from our mistakes or our opportunities for improvement and make us a learning organization where even if failures do happen, we all come together and analyze the event and be able to learn from it. So this slide shows us that for 2017, we had a 67% response rate. And this is in comparison to the 2015 Safety Culture Survey that ended with 55%. Across the nation for 2017, the participation rate has been at 55%. So JPS has surpassed the participation rate compared to other hospitals in the nation.
Who do you survey?
Our team members, sir. So so that's a great question, Dr. Weber. We're actually, for this survey, we actually surveyed our patient-facing team members. And also, this year, we partnered with the TCU School of Business in administering the survey. In the 2015 survey, we used NRC Picker. So these are an overview of the results. You notice that we have the word positivity score. So what this means is we actually scored 49.5 or at the 50th percentile nationally on our positivity score. And what this means is our team members rated us with an agree or strongly agree when asked about our safety culture here at JPS. A strength, and we have one major strength, and then 2 areas for improvement. And our strength is actually our senior leadership team. We have a very good communication process. We allow for our organizational learning, and management promotes patient safety. Whenever our senior leadership team conducts their executive rounding, this actually provides an opportunity for our team members to be able to approach them and mention any events or issues they may see as impacting the way that we care for our patients. An area of weakness would be teamwork within our units and also across units. An example would be our ability to communicate when we need help, or if we are transporting a patient. So these are areas of where communication within and among units is important. And then the other weakness would be the frequency of events reported. From last year compared to this year, we have done a great job. Our patient safety team has done a great job of improving our openness regarding reported events. And we currently are using MIDAS as our notification system. And our unit leaders, our nurse managers, our nurse directors, even our ancillary leaders in pharmacy, PT, ambulatory care, we are always, and behavioral health, we're always very open to working with our staff regarding the reporting of events, although it is considered an area of improvement in the survey.
Go back one more.
Yes, sir.
On the non-punitive response, which at 39, you don't consider that a weakness?
Yes, that is a very good point, Mr. Win. Our researcher, what he did was he looked at all the responses and compared us with other organizations across the U.S. And based on what came up from the survey, these were the themes. These were the common themes because aside from the responses where staff will answer disagree or strongly agree, they also have comments that provide insight into their responses.
Right, but we'd be below average from the national average, and it's still not a weakness?
So in the next slide, I'm going to address that, sir. In the next slide, yes. Yes, sir.
Before you leave from that, did this survey was done by the TCU?
Yes.
Okay, and the previous one was done by whom?
NRC, Peaker.
Okay, so when we went to TCU, how large is their database and how many hospitals is in it?
So, very good question, Ms. DeBose. So, when I mentioned about the AHRQ survey, AHRQ developed the survey in itself, in substance and content, it stays the same. However, the organization has the ability to choose the vendor, so to speak, that would administer the survey. So, if you ask the question between NRC and TCU, it's actually the same survey and the benchmarking is actually the same because we can benchmark with other hospitals that took the survey.
So, let me make sure I understand that you use the same survey, the vendor was changed, and the vendor has access to the same database?
Yes, ma'am.
All right.
Yes, Reverend.
The percentages under 2017,
Yeah.
that those percentages are a result of whom? Just us?
Yes, sir.
Okay.
And then the national average, Reverend, would be next to the percentile. That will be how we compare with other organizations.
Then let me go over to the weakness. When we discover that that's a weakness, then there is a repair plan or plan to address that to bring us.
Yes, Reverend. That will be part of our next steps. We actually met with our TCU researcher last week, and part of our next steps would be to work with the unit level managers, making sure that we provide them with the results of the survey and we can create an action plan.
The reason I asked that because when I looked, I was with DT on the 39%, but when you look at teamwork across units, was weak, and no, teamwork with units and teamwork across units, yeah, were weak. Hope I'm got that right. Because I thought that was a couple of our strengths in the system.
That's a very good point, Reverend and Mr. Win. What I can do is we can circle back with our researcher and ask him what would be the factors that would not have allowed him to put a non-punitive response as part of our weakness areas. And definitely I will provide an update to you on that.
Okay, but not just the non-punitive. I guess I really focus on the two teamwork areas show weakness, and when you hear reports at the table here from staff, and you see that has for me, I I've noticed in my time here, that has been a strength for JPS, the teamwork that takes place within our system, and I'm surprised that it's saying it's a weakness upon here now.
That's a very good point, Reverend. Yes, and we do have a lot of packets of teamwork here at JPS. However, in the results of the survey, it does allow us to reflect and ask the questions, why was this the result of the survey, and how can we make sure that what our perception is and what our staff members perceive is the same and consistent.
So evidently, Robert's not doing breakfast for every unit in the hospital, is that what it's saying?
Well, or else it says that the other 33% were totally happy with everything, that's why they didn't respond.
Okay.
Okay. All right, other questions, comments? All right, go ahead.
Thank you, sir. So we looked at what are the factors that drive culture of patient safety at JPS. And the three areas that came up would be senior leadership, teamwork, and reporting errors. So this actually ties with what was mentioned earlier regarding non-punitive response to reported errors. Under here, you will see the job satisfaction, organizational identification, perceived impact of work, and team dynamics are all constructs of employee engagement. And our HR team and the rest of our leadership team has done a great job of engaging our team members to ensure that, you know, our constructs of employee engagement help drive a culture of safety here at JPS. So lessons learned, patient safety culture for JPS increased by 1%. Today we are at the 50th percentile compared to other US hospitals. Our new hires rate patient safety culture higher than experienced employees. And then employee engagement, that is job satisfaction, organizational identification, and empowerment, all drive our patient safety culture perceptions.
Okay. Other questions, comments?
Well, I have, I'm just having a hard time reading. If you go back one screen, can you flip back one screen? And, no, go forward one more.
This group, the driver's coach.
Right,
This
my concern, and you might want to go back and look at these. Because when you see political skill is a plus, right? And then you see meaning of their work is a minus. That's a big concern there because somebody's speaking and somebody's not following. So sometimes that may not be right. You may want to review their work to see if that's true, because that's kind of very, very hard for us to understand why there's that discrepancy. Right?
Yes, thank you, sir. Very good point. The way that the meaning of work is defined and competence in work is defined is that our employees find purpose and meaning in their work. And based on the results of the survey, this was not rated higher compared to the other drivers. And
I don't know what the makeup of what you mean by political skill. We may need to break it down.
Yes, sir.
Because for me, when I see that, just plain speaking, if you're looking at the population of your employee, then they know how to manage up, but they don't manage down. You see, so it is concerned because we may not get the information, like the leadership may not get the information that they need to operate the system when middle management manage up. But it's so general, so we can't
Yes, sir.
tell. So
Yes.
maybe that's an opportunity to break it down even more.
Thank you, sir. Very
Because
good
it's
point.
a concern
Yes.
because it's casts a different light of the culture that we see. So it was a little bit.
You are correct, Mr. Win. This is very high level. It's very global. We did not go into the details. And political skill, as you have described, is actually what this political skill means. It's the individual's ability to navigate the system. And you are also correct in saying that our middle management, we actually have a culture here at JPS where we should be able to manage up our team members. However, in this specific survey, we are usually constrained because these are the global terms that the ARC survey uses. And we will definitely look into your suggestion regarding looking at more at the details, especially when we discuss this with the unit managers. Yes, sir.
I just have one question. So, I understand the factors that drive it, but is this senior leadership's, is it what they believe, or is it what the employees of the institution believe at senior leadership?
Yes, sir. The latter would be how our staff members perceive our senior leadership.
And when we're talking about senior leadership, are they viewed by all employees, or is there a break-off at a vice president up level, or is there a break-off within that demographic group that's making the assessment of senior leadership?
Great question, Mr. Powell. So when we mean senior leadership in the survey, what it's talking about is upper management, and that would be our vice president and up.
Okay, but the decision, or when it says senior leadership, that's what vice presidents and up think of their fellow teammates, or is it what all the employees within the district think of vice presidents and above? I'm just curious as to the assessment. It's not senior leadership talking about fellow leadership. It is just, and I'm not using the word rank and file, but it's the majority of our other 6,500 employees, what they see of senior management determined as vice president, most likely levels.
Yes, sir.
Or above. Okay.
So it is the perception of our team members, of our senior leadership, and that would be
Right.
vice president and above.
Okay.
So to me, factors driving the culture of patient safety, across the board negatives would be something that would merit our attention, and across the board positives, it means we're doing fine. So we have something to focus on.
And when it has a negative sign, I know that the negative sign usually would have a not so good connotation. But here for the negative sign, what it means is that in the survey, it was not seen as a driver for culture of patient safety. So, so meaning to say it was not seen in all of the responses. And the ones with the positive sign would be the areas that our team members felt strongly about.
So with that, are you saying?
I'm confused.
So what you're saying is that these, in the various factors and drivers that are being discussed, some of these elements were more important to the issue of patient satisfaction than others. And so job satisfaction was universally seen as a driver of patient satisfaction, but meaning of the work, nobody really cares if you know the meaning of your work. We just want you to do a good job and get good results. Is that what you're trying to say?
It was the respondents' perception, Mr. Norrid. So based on the results of the survey, it was not rated as strongly compared to the other components.
So it's not a positive negative, it's just a driver or less of a driver.
Yes, sir.
I have a question. If it's not important, then why did we have it on the survey? Because I do think that someone, if you had competency in their work, there was some evaluation given, right? And so some staff is saying, in this area, this is what we believe. And it's not a driver.
Yeah. It did not come out as a driver, Ms. DeBose, when we looked at the 3 themes, and the 3 themes would be senior leadership, teamwork, and reporting errors. One of our limitations with the patient safety culture survey is that it was developed by the AHRQ, so we cannot really change the questions because it will not allow us to benchmark with other organizations in the country.
Yes, ma'am. I'm sorry. Ms.
You know,
Calvin, go ahead. Sorry.
You know, the few times that I have had to write a report, I come in as a patient, I'm greeted by somebody who's snarky, you have no idea who I am and what I do here or anything like that, and I just get on my computer and I just write this whole dissertation about what my experience was. And what I'm thinking is, and I've gone back and I've sort of mentioned this to Debbie, I really don't think that many of the employees understand the new push forward or the new way of doing things in the hospital. I think you have a culture that has been, they're satisfied that they have a job, they've been here 10 or 15 years, they know how to do everything, whatever, but they're not in here, so they don't understand the meaning of their work, competence in their work, and self-determination has everything to do with how your managers and top brass sees job satisfaction and doing it. They don't understand it because it's not in them, and that wasn't taught to this base. Your new people coming in, they're understanding because they're coming in with the new culture, but you have a lot of people that really just don't understand. My how do you say, surprise was that many of the employees that I interact with when I come down here, and even in the clinic I go to Watauga, don't even know what Patient and Family Advisory Board is. They have no idea. They just look at you as if, you know, what is that? So I've asked Debbie several times, I said, you know, do you put something on the bulletin to let you know what this is? And in other words, you're being watched a little bit, so be careful of your attitude, the way that you handle your patients and so forth, because they have a place to go to now that will, and Ms. Calvin will be there in a zip. You know what I'm saying? But they don't even realize that. So I don't know. These three things have everything to do with your job and keeping your job and doing the job that JPS wants them to do, but they're not getting it. And they won't get it until somebody tells them, this is the new way of doing things and this is where we are, and go forward.
Yeah, if I could just make a suggestion, what Ms. Calvin just said, that I think we may have to look at a different way we present the results, because I think we're all sitting here mentally going, how in the world can, if it's the rank and file our employees, ever how many thousands there are, if they're giving this, I just don't think that many of them think that the senior leadership in this hospital is basically incompetent. And I think if you're not careful, you could read that off that list. I mean, because it's a negative setting. So I'm just not for sure maybe the presentation of the facts derived from the survey. I think we're getting all caught up in the plus and the minus, and I know these are the factors that drive it. We've already seen the results on the previous slides, whether we fit in rank and file, but I just think we're all getting, myself, I mean, it's, you look at that and you go, well, how in the world could everybody think job satisfaction and senior leadership, and then you get down there and, well, but they're not competent in what they do, and they don't even know what their meaning of their work is. I think we're caught up in things there. It might be able to be presented, is all I'm saying, a little bit different meaning as to what those factors do. That's, well, I think we're all kind of having out here the questions, and we're all caught up in the plus, the minus, and what someone else thought on the survey. It just might be a more clear way to present that.
I think with the opinions expressed, as the chairman, I promise, Mona, that you and I will sit together and look and talk at this, so that as an action item going forward, next year we might be in a different place from today. Overall, everything looks pretty good, but the exceptions, I'm more than willing for you and I to address if we get some work done on it. Okay, everybody comfortable with that?
Yes.
I think that's a good way to do it.
Again, it's really not a matter of looks pretty good.
Yeah.
This report doesn't show what's pretty good. This report just shows what was perceived as important to the issues of patient satisfaction. There's no patient safety. Sorry, I keep saying that right. I've said that several times. My apology. That's just what's perception of what the drivers are.
Right.
It's not a pretty good or not a pretty good thing, right?
Perception reality.
Are we otherwise in agreement? Other comments? Thank you, Mona.
Thank you.
Okay. Laura Burnside, come forward and be acknowledged, please. Thank you. Welcome.
Thank you. Thank you for having me. Again, for those who were in the last meeting. I am actually, okay. No, I got it, actually, yeah. So I am actually here to talk about caring for our caregivers and how that impacts and has an impact on patient experience. What we know nationally is that compassion fatigue and physician burnout are very prevalent among the majority of our nation's caregivers. We actually saw high to medium burnout in the pilot group survey that we did last month here at JPS, and so we're right here in the middle. So we decided to say, what if we took this epidemic, but we started creating a positive epidemic within it? And how can we do that in order to drive engagement levels, reduce burnout, increase physician well-being, and also reduce compassion fatigue? So the first project that we are implementing, some of you heard me speak to a moment ago in the governance board meeting, but I'll repeat some of the elements just for those who were not there, and wanted to be sure, Ms. DeBose, I do have the list. So JPS was one of 7 hospitals nationally that was selected to participate in a pilot. And among
What were those other 7 hospitals?
Funny you should ask, Mr. Early. We are actually participating in the pilot with Intermountain Health, which is located in Salt Lake City, Einstein Medical Group, which is in Pennsylvania, Phoenix Children's in Phoenix, Arizona, Tucson Medical Center in Tucson, Dayton Children's in Dayton, Ohio, and Centara Medical Group, which is in Virginia and parts of North Carolina. Okay. So there we have it. So the goal of this project is really to start to create an environment where our physicians can thrive. And
Can I ask a quick question?
yes, absolutely.
Any one of these hospitals have safety net hospital?
No, these are not, no.
Okay.
Not in the pilot itself. So we actually have an opportunity to set that bar.
Right, because our people probably with trauma and everything else probably have a high intensity.
Yes.
Well, we're on that list for a reason.
Yes.
We're on that list because we are the public hospital. We are the safety net, and I think we're going to bring a huge amount of information and perspective because we are.
Yeah, they're very excited about that element, you're right, and that is part of the reason why we were selected. The bottom line to this is that when we have engaged physicians, we actually end up increasing trust, increasing compliance levels, and our quality outcomes improve. And so we know that from all of the research that's been done over the years and throughout the years. And so this project is actually designed by physicians for physicians, and as I mentioned earlier, it's for us to work with them and for us to work for them, rather than it being the at and two Ps. The design of this project is the learn, do, share model. So our physicians will learn a new skill or tactic in the modules that are designed by physicians. They will then do the specific behavior that was learned, and then they will share that with their colleagues. And so this is really kind of a grassroots effort for us to be able to focus on some of the key aspects of this project, which are quality and safety, physician well-being, patient experience, and clinical leadership. And what we know is that when we do have increased provider experience, we get better patient care, better outcomes, and our patients have a better experience while they're here. And by the way, we will actually kick this project off tomorrow, so the 5th of May already. Part of the design of this is for us to really look at empathy and compassion, and the latest research shows that 62% of a patient's experience is actually related to empathy and compassion, and so that's a large percentage for us to be able to really move forward in. So that takes care of sort of the physician aspect, but then the question is, what do we do with the rest of our caregivers that are here at this hospital? And so we actually are participating in another really phenomenal group that is called the Schwartz Center for compassionate care. And this organization is actually a nonprofit, and they work with 425 hospitals in the United States. And then additionally, they have 150 organizations, pardon me, it's 425 in the United States, Canada, and New Zealand, and then 150 that are in the United Kingdom and Ireland. So they're spreading throughout the world. And the design of this particular organization is to really provide us an opportunity to support our caregivers in a way that we may not have done in the past. And it's really a structured outlet for our caregivers to be able to express their feelings. This is not an analysis of what happened in an event, but rather how did that caregiver feel. And if you can imagine as a person that's here taking care of patients, you may go into one room and it's a very wonderful situation, very wonderful outcome, and then you move to the next room and it could be something very tragic. And as a human being, how do you actually handle that emotional variance? And so this is really that design for us to build that net for our caregivers to be able to talk about that. So it's a safe place that we will bring our care team together. It's open to whomever wishes to join the sessions. Well, right now we're scheduled to have them every other month. They are some at breakfast and some at lunchtime. So we part of the Schwartz Center model is that you provide a safe place and you provide food, because it's a comfortable, very safe environment for our care team to talk about the work that they do and the human and emotional impact of that work to them personally. So it's really, the design of it is really about the human dimension of healthcare, not necessarily the analysis or root cause analysis of why an event happened. And then again, just, what we know for sure is that when caregivers feel supported, they're more engaged, and that more engaged workforce leads to better patient outcomes for all those we serve. So in the end, how will we measure our success? And this was actually asked in the last meeting as well. We know that our patient experience survey data will change. We know that our comments from our patients and our guests will change, even for the better. Although both of those are pretty good right now. So it's a matter of us being able to just continue to move that needle. So we'll see our quality metrics improve, our physician and our employee engagement survey results should improve as well. And in the end, just be able to have a workforce that feels very supported by the organization and also very supported by each other. What questions can I answer for you on either of those projects?
I'll have one quick question.
Certainly.
The Schwartz Center, it will have a location, or it's
No,
just
it's
a?
here. Yes.
Not, you say here, not this room, I mean,
It
here
is
with
this
the.
room, yeah.
It is this room.
It is this room, yeah. Will be transformed, right?
Okay.
So we actually, they actually train us to facilitate these sessions. And so this organization has already conducted a training session for, I've actually participated, and Jeff Christie, who is our leader for our employee assistance program. And he and I have been trained on how to facilitate these sessions in-house. So the Schwartz Center is there for support and guidance and to be able to help us through any of the obstacles we come across, but they've really designed it to train, and we will hold it here on campus.
I personally would never ask this question, but Reverend Emerson has asked me to ask you, is the slogan, "May the Schwartz be with you"?
So
It's a movie line.
yeah.
Schwartz Center, May the Schwartz be with you.
That's
Movie
it.
involves the movie.
Moving
Just
along,
lightning moving
moving along, Mr. Chairman.
Thank you very much. Take this very seriously.
Very well.
And may the Schwartz be with you.
Yeah.
Our DP has a question.
Yeah.
I have a question
Yes.
on, have we thought or defined what would the,
Really bad movie.
sorry, what would be the ideal place to be? Calm place or high intensity place, or have we ever thought that far yet?
As far as our care team goes?
Yeah, at the end goal, at the end of the day, what do you want?
Well,
What are we trying? Because each institution
yeah.
may define the level of engagement, patient participation, or burnout differently, right? Sometimes high intensity doesn't create burnout, but some area high intensity will create burnout.
Sure.
So what are we? We might not know now, but as it progresses,
Yeah.
at the end of the journey, what are we? We'll continue to improve, but have we know our characteristic so that we can fit in to what's idealistic for our place?
For JPS. So, I'm going to defer over here to my colleagues that practice, particularly those who practice in high stress
For me,
areas,
it's
right?
inclusion also as well, right? Because at the end of the day, this is our family.
Yeah,
So
without a doubt.
how do we define what is burnout? Like for my kids, I can push them to the limit. It could view as burnout.
Yeah.
But for our people, for certain things that we do, it
Yeah.
may not be considered burnout. So I'm just trying to
Yeah.
find that happy medium where we might, I know we don't have an answer, but that's something that we might want to start
Sure.
looking.
No, it's a great point. And I think that's why now today, what you hear is not necessarily work-life balance, but rather work-life blend.
Right.
Because even that is different per person, right? So some may choose to practice in really high-stress environments, and some may choose a lesser intensity. But at the same time, we've got to find that blend and that balance for our employees. So
Because
your point's well
I
made.
noticed the 6 hospital system on a different region also as well. And that does dictate how
Yes.
people culture and everything else also as well.
You're right. You're right. You're right. We'll look at that.
Other questions or comments? Thank you for knowing the list.
I-
And what are the 6 hospital again?
Thank you all so much.
Okay, without further business or ado, I think we'll move to executive session, and we'll reconvene in a while. We have a significant number of items that I think I know of, so this is not going to be a 5-minute executive session, I promise you that. I'll explain later, it's a movie. We're reconvening in open session for the Quality Committee. I'll ask if there's any other business to come before the board. There are no privileges to review at this time. Entertain a motion otherwise to adjourn.
So moved.